And for those of you who don't know me, I'm the director of the National Center for Medical Consequences of Spinal Cord Injury, which is a unit that's been at the VA as a VA funded unit for the last 21 years. And before that, it was funded by Eastern Paralyzed Veterans Association, which then morphed into United Spinal. And they had supported me for about 10 years before that. So I've been at this game for quite a while. So what I'm going to discuss with you today is an area that has been of intense interest to me and my collaborators. And I hope that I can, instill interest in you as well. I think it's a very important area, especially for those of you who are, doing rehab medicine. And what I'd like to do is, briefly discuss some of the physiology and findings in persons with spinal cord injury. And we're going to break it up into those who have more recent or more long-standing injury. And I'm going to discuss the pharmacologic interventions. There are, as you are well aware, rehab interventions in persons with spinal cord injury that may have an impact on bone, but for the presentation today, I'm going to stick to drugs, and I'm going to talk about drugs in those who have acute spinal cord injury, and that's from clinical research experience. And I'm also going to delve into some preclinical findings. There is very limited clinical research experience in those with chronic SCI, but I'll just mention a couple studies in that area. So what are the potential mechanisms of bone loss in persons with spinal cord injury? And there are several. Reduced neurologic activity can have an impact on bone. Impairment of local circulation, that's circulation in the canaliculi, that can be depressed if you're not moving around and loading. We have shown many years ago that men with spinal cord injury have depressed testosterone and growth hormone. Those are the two anabolic hormones. And parathyroid hormone is anabolic to bone. And as you know, it's prescribed intermittently to increase bone mass. So if you're lacking parathyroid hormone or for a period of time, that may negatively impact bone and bone mass. These changes, though, mostly are secondary to reduced mechanical load. And shown on the left is histomorphometry of normal bone, and on the right, osteoporotic bone. And one can appreciate that there is thinning of trabeculae, and there may be loss of connectivity as well, which would reduce the strength or the integrity of bone. This is a article that I enjoy showing because it's very simple. It just shows that in 3 regions of the leg that there is bone loss over time, and that those regions lose bone at somewhat different rates and magnitudes. Bone loss at the femoral neck occurs and appears to plateau off after about 18 months with about a 40% loss. The proximal tibia also appears to level off at around 18 months with about a 60% loss, a tremendous loss over that period of time, whereas the femoral shaft loses bone more slowly, but appears to continue to lose bone even out at the last time point, which is 53 months. Esser studied 89 individuals with complete motor spinal cord injury, and she did so by a method known as peripheral quantitative computed tomography. And what this permits one to do is to look at compartments of bone. And by doing so, the investigators showed that at the epiphyses, or the tip of the bone, that about 50 to 60% was lost in the femur and the tibia. In the shaft, by contrast, About 35% was lost in the femur, and about 25% was lost in the tibia over a period of about, give or take, 7 or 8 years. And this cortical bone loss occurred by end osteal resorption, resorbing from the inside of the bone out. And one should, of course, realize that even though the percentage of bone lost in the shaft was much less than the epiphyses, that 80% of bone is present in the cortical area. We had the opportunity to look at sublesional bone loss after acute injury. And in the distal femur, bone loss appeared to level out after give or take 14 years. In the proximal tibia, 10, 11 years, bone loss plateaued. In the femoral neck, once again, it was up around 14 years. And in the total hip, bone loss plateaued after about 6 or 7 years. So one can see that regional bone loss is region of the bone specific. We had the opportunity to do a monozygotic twin study, and the figures you see below, each point is the non-spinal cord injured twin subtracted from the spinal cord injured twin. So it shows you the loss in bone in that spinal cord injured twin with a perfect control. And one can appreciate that leg BMD or leg BMC, bone mineral density or bone mineral content, appears to continue over the decades of life. This work by Zendler in over a 30-year period, it's a cross-sectional study. In 15 of 98 individuals, they had 22 episodes of fracture in which 39 fragility fractures occur, and that's seen in the figure on the right. Most of the fractures occurred later after injury. Very few occurred early. And this makes perfectly good sense. If you have bone that's lost over time, the more bone you lose, the more apt or fragile that bone will be for fracture. And various investigators have tried to define a fracture threshold. And in this work, the investigators looked at the bone of the tip of the femur or the tibia and tried to define a level of BMD below which individuals were at highest risk of fracture. And here we see at the femur at about 112 milligrams per centimeter cubed of bone, below which individuals fractured. But you also see that many individuals below that level of femoral density did not fracture. So there are other factors at play here. And the other factors one can consider are the geometry of the bone, the composition of the mineral density, and I'm forgetting something, but I'll remember it. And of course, the architecture of the bone. So that, in addition to the level of activity that individuals have, will determine fracture. If someone is far more active, they are at greater risk of fracturing. But there is a level of bone, and this is fairly crude. And I think in the future, we'll be able to better define fracture thresholds by doing more sophisticated analyses, such as finite element analysis. So what are the strategies to maintain skeletal integrity? in acute spinal cord injury, what you'd like to do is inhibit the cell that chews up bone, or the osteoclast. And if at all possible, to do that while maintaining function or even stimulating the function of the cell that makes bone, or the osteoblast. Although of importance, probably alone or in combination with pharmacologic therapy, or the rehab interventions, but they are not the topic of discussion today. Some of these interventions have been shown efficacious alone, such as functional electrical stimulation, but there's work being done to show that possibly suspended walking or spinal cord stimulation will be associated with improved outcomes. So let's then go to the pharmacologic interventions in those who are recently injured. But before we do so, let's discuss, a bread and butter issue. You need calcium in order to build or hold on to bone, and you need vitamin D levels at a sufficient amount in order to absorb calcium. So we appreciate that many of our patients with spinal cord injury may have insufficient or absolutely low levels of vitamin D. And that's because of various reasons. You don't see too many individuals with spinal cord injury at the beach sunbathing. Often those with spinal cord injury were told at time of acute injury to avoid dairy products, which of course may be a source of vitamin D in milk, and medications may increase hepatic metabolism of vitamin D, specifically those that soup up the P450 fraction and result in further hydroxylation of vitamin D to more polar metabolites. If vitamin D levels are low, there are many ways that one can supplement vitamin D, but we have found that if you give 2,000 international units a day, that vitamin D levels will rise into an acceptable range within a month or 2 or 3. Of course, if you have adequate levels of vitamin D, that alone will not improve your calcium absorption. You need calcium. So to do that, we recommend that you take 1 gram or 1.5 grams of elemental calcium per day. So moving on to the pharmacologic approaches to maintain bone mass after acute SCI, bisphosphonates are used most commonly in postmenopausal osteoporosis and have been used in patients with spinal cord injury on several occasions, but their efficacy is questioned in individuals who have complete motor lesions at the knee. Bisphosphonates probably are useful at the hip, but less so at the knee if you're a complete motor injury. Denosumab, or anti-receptor activated NF-kappa B ligand antibodies, human monoclonal antibodies, we have found to be quite efficacious in preventing bone loss both at the hip and the knee. Drugs that have not been formally tested at time of acute spinal cord injury are testosterone, and this holds promise. And several animal studies, especially those by Yarrow, have shown that testosterone replacement therapy is a potent way to maintain or at least prevent much of the loss of bone at time of acute spinal cord injury. And as you are aware, in men at time of acute spinal cord injury, there is a precipitous fall in testosterone that lasts a good length of time, several months or even longer. Parathyroid hormone may be of value in treating those with spinal cord injury, especially if it's used in combination with other agents. And parathyroid hormone analogs may also be of use. And there's one commercially available, as we know, that is abaloparatide, and that has not been tested yet in the setting of acute injury. Anti-sclerostin antibodies hold tremendous promise. They're both potent anti-resorptive agents, and they also have the hold the potential of not suppressing bone formation. So I'm going to talk probably ad nauseum, more than you ever want to hear, about bisphosphonate therapy in acute spinal cord injury. And I'm doing this because I think you should familiarize yourself with the literature, but also because I want to highlight the limitations of bisphosphonate therapy in those who are recently injured. So here I broke up the slide into motor, complete and incomplete injury, but also into those who participated in clinical trials versus case studies. And here I show that the bisphosphonates that have been studied include alendronate, pamidronate, and zoledronate. There have been others studied, but these are the main three. And this work by Pat Nance shows, and let's look at the left-hand panel, that if one has a complete motor sensory lesion, an ASIA A, that if you give pamidronate, that there may be some improvement. And this was percent change from baseline in all regions of interest that were acquired. But if you have an ASIA D lesion and can get up and about and walk around, and you give a bisphosphonate, that this appears to be highly efficacious in preserving bone mass. Looking at the right-hand panel, if one looks at the distal femur and proximal tibia, one sees that pamidronate appears to be efficacious, but the authors did not separate out complete from incomplete lesions. So we can deduce from the left-hand panel that most of the benefit of giving a bisphosphonate at the knee was in those who could ambulate. Gilchrist studied 31 patients who were captured within 10 days of acute SCI. So I really take off my hat, because it is so difficult to recruit patients with SCI to a bone study, and to do it this early was a feat. And let's see what he found. At the total hip, trochanter, femoral neck, and femoral shaft, alendronate was quite efficacious in preventing loss of bone compared to the group that received placebo. Of note, alendronate can cause esophagitis. If you reflux back into the esophagus after you take alendronate, it can be quite irritating. And that can pose a problem in persons with spinal cord injury. Initially, alendronate was given as a daily medication, but in this study and nowadays, we give it once a week or possibly even once every several weeks. So it is a drug that may be considered, with the caveat that it can irritate the esophagus. Bulbar studied initially 14 patients with early motor complete or motor incomplete spinal cord injury. And at baseline, he had equal numbers in each group, but then dropped down to 5 in the drug and 6 in placebo. And he also found that if you look at either the total hip or femoral neck or trochanter, so that's regions of the total hip, that drug therapy prevented at least some of the bone loss. But once again, as with the work that was done by Gilchrist, the knee was not studied. Shapiro gave a squirt of zoledronate or zoledronic acid at baseline and did BMD and structural analysis of the proximal femur. And this These figures are fairly complex, but I think I can explain them to you in a prompt manner. The study participants were divided into placebo or PBO or drug therapy, which was zoledronate, ZOL. So you see that each panel is divided into placebo or zoledronate, and that you have 3 bars for both the placebo and the zoledronate groups. The first bar represents the femoral neck. So I'm pointing to the femoral neck in the figure and the femoral neck in a radiograph of the hip. And then there's the intratrochanteric region. Once again, I'm pointing to both, and the femoral shaft. And that pattern is repeated throughout in the placebo and the zoledronate groups. And one can appreciate that early on at 6 months, that there is a benefit to giving zoledronate. And that's true also for cross-sectional area, section modulus, which is a measure of the bending strength of the bone, and the buckling ratio, which is negative, which is good after you give drug, because that's an index of cortical instability. So at 6 months, the drug appears to have a great benefit. But if you look at 12 months, much of that benefit appears to wash out, and there is significance that appears to be retained at the femoral neck and the femoral shaft for bone mineral density, and possibly also for the femoral shaft for cross-sectional area. But according to Shapiro's work, much of the benefit of a single dose of zoledronate washes out at 12 months. So now we turn to some work done by our group using pamidronate, and we wanted to give a sufficient dose of drug over a period of time to show an effect. So we overdid it. We gave it a baseline 1, 2, 3, 6, 9, and 12 months. So if there's an effect of pamidronate, and we were mostly interested at the knee, even though we looked at the total leg, we would see it. And another bisphosphonate that we studied was zoledronic acid, and we gave a single dose at baseline, and we looked at 6 and 12 months. So one can appreciate that after giving either pamidronate or zoledronate, that there wasn't that much difference between the placebo group or the drug group. And if one were to look at the 12-month time point after giving zoledronate, one sees that indeed, as other investigators have shown, that there was a improvement in retention of bone at the total hip and the subregions of the hip after giving zoledronate. However, at the knee, and the knee is important because that's the site where most individuals with spinal cord injury will fracture, there was clearly no benefit of treatment and possibly even an adverse effect of giving zoledronate at the knee, distal femur and proximal tibia. So our work was confirmed by Olson, who also found that giving zoledronate was efficacious to preserve bone mineral density at the hip, but it did not reach significance to preserve bone at the knee. So, is there anything else that we can give to improve outcome at the hip and the knee? We appreciate that rankle is a cytokine that stimulates the recruitment of osteoclasts and its viability and activity. So if one were to inhibit rankle, and one can do that with a monoclonal antibody to rankle, and that is denosumab. Let's see what was done after administration of that agent. And in 14 men with motor complete spinal cord injury, denosumab was administered every 6 months for 12 months, and biomarkers of bone turnover and BMD of the hip and femoral neck were studied. Once again, these were individuals on average who were studied a little over a year after spinal cord injury. So one would expect to have continued bone loss. And what one sees is that the total hip and the femoral neck, after giving denosumab, that there is no bone loss and possibly even a little gain of bone. And if one were to look at markers of bone turnover, bone outphosphatase is a marker of bone formation or osteoblast activity, and P1NP or procollagen type 1 N-terminal propeptide was depressed, as was alkaline phosphatase, and the C-terminal telopeptide, which is a marker of bone resorption, was also depressed. So bone turnover was suppressed, and bone loss was prevented. In another study by Gilfrey, and Gilfrey is out of the SCI group in Barcelona, 42 males with acute motor spinal cord injury were initially studied, 18 were lost to follow-up, and then 23 were followed. And of those 23, 15 had evidence of the hip of osteoporosis and were begun on denosumab, and 6 were begun at 12 months and 9 were begun at 18 months. And they looked at osteoprogerin or OPG, rankle, and hip BMD. And what was seen was that if you had a negative change in rankle, that you had preservation of total hip BMD. So the change in total hip BMD was smaller if you had a large negative change in rankle. If you had a more favorable, that's in the left-hand panel. The right-hand panel, if you had a more favorable ratio of OPG to rankle, that PTH levels tend to be higher. And that makes perfectly good sense, because if you reduce bone resorption, ionized calcium levels will be lower, and that will be permissive to the release of PTH. Our group looked at denosumab in individuals with acute motor spinal cord injury. In this study, we had 10 on drug and 8 placebo, and denosumab was given at baseline, 6 and 12 months. And let's see what we found. Remarkably, total hip, distal femoral metaphysis, distal femoral epiphysis, or proximal tibial epiphysis, as a group average, denosumab was incredibly effective in preventing bone loss. If one were to look at the individual values in individuals who either received denosumab, those are the black bars, or placebo, those are the gray bars, one can appreciate that at the distal femoral epiphyses or proximal tibia epiphyses, that denosumab was highly effective compared to those who received placebo. However, there was an individual participant who lost more bone than we would have liked. And that's probably because that individual escaped from the drug effect. And I can hypothesize that if we had shown that by measuring biomarkers at 4 or 5 months, that the biomarker for resorption was creeping up, either an N or C-terminal telopeptide, that if one had given another dose of denosumab at that time, one might have prevented the loss of bone. Another alternative is to give a higher dose of denosumab at 6-month intervals. Moving on to chronic spinal cord injury, we all appreciate that the bulk of patients with spinal cord injury have had it for a period of time. But the problem is that we just don't have a good agent to treat these folks with. And we appreciate that it's very important nowadays to hold on to bone, because we have various rehab interventions that permit us to get folks up and walking again. So, what has been done? Well, there has been some work done by the administration of parathyroid hormone, or Forteo. And in this study, which was an open label study, Forteo was given daily, plus robotic assisted stepping, which was done 3 times a week. But the investigators found that there was no benefit to giving the combined pharmacologic and mechanical intervention. These investigators also studied the effect of vibration alone, teriparatide alone, or teriparatide with vibration. And even though you can see from the results that there were some increases in the PTH group to spine or to hip or to cortical knee by various imaging modalities, the investigators concluded that the benefit was not expected to provide any relevant clinical benefits. The other takeaway is that even though there were increases in many of the endpoints, they did not reach significance. Another point is that in chronic spinal cord injury, there has been a tremendous loss of bone, and what you're trying to do is to reverse that loss. And you can see, I'm putting the arrow at 0 or baseline, that if you give TA is teriparatide alone, or VA, it doesn't stand for Veterans Affairs, it stands for vibration alone, or the combination TV, that you really don't get much reversal of the bone loss that you would like to see in treating someone who has long-standing spinal cord injury. So let me launch into a little discussion of some of the preclinical work that we're doing with either sclerostin antagonism or Selig-15 antagonism. And we appreciate that the Wnt signaling pathway is necessary for bone health, and that there are various inhibitors of this pathway. And one of those inhibitors is sclerostin. So sclerostin will go up in spinal cord injury along with DKK1, which is another inhibitor of that pathway. And in doing so, it'll reverse the OPG to Rankel ratio. It will decrease it. That'll cause an increase in osteoclast, which will result in increased bone resorption. So what occurs if you give sclerostin antagonism to a rodent after spinal cord transection? And what you see is that after spinal cord transection, there is a significant loss at the distal femur and proximal tibia, which is reversed pretty much by giving an agent that will antagonize the inhibitor of the Wnt signaling pathway. So you have an inhibitor of an inhibitor producing a positive outcome. And across the top, you see a scanning electron micrograph of sham SCI and SCI treated animals with sclerostin antibody, and one can appreciate that compared to the sham, the SCI bone is quite depleted, but after sclerostin antibody administration, or I should say with sclerostin antibody administration, that the bone appears to be more normal, more like the sham. And if one were to look at various endpoints, if one looks at bone volume for over total bone volume after SCI, there's quite a loss with SCI, but that loss is by and large reversed if one performs sclerostin antagonism. Trabecular thickness is decreased after spinal cord injury, once again, totally reversed with sclerostin antagonism. And if one were to look at trabecular number, it is decreased with spinal cord injury and somewhat improved with anti-sclerostin antibody. However, a connectivity between trabeculi is not improved after sclerostin antagonism. If one were to look at scanning EMs, the sham animal top panel shows that you have osteocytes, and osteocytes, as you appreciate, are the cells that make up 80 to 90% of cells in bone, and they orchestrate bone function. In the sham EM, one sees a very finely reticulated and coordinated dendritic pattern with cells that are well oriented. In the middle panel, you see that the cells lose their orientation and there's a tremendous loss of dendritic number. And in the bottom panel, one appreciates that cells are better oriented. You have more dendritic projections. And if one were to quantitate osteocyte number dramatically decreases with spinal cord injury, but appears to be more or less normalized with sclerostin antagonism. Dendritic number also is decreased after spinal cord transection and is reversed to at least sham levels with sclerostin antagonism. Now let's turn to anti-celic antibody, which is sialic acid binding immunoglobulin like lectin 15, which is a lectin receptor that's found on immune cells. And we appreciate that osteoclasts derive from an immune cell, from the monocyte. So it's not too surprising to find anti-celic 15 antibodies on osteoclasts. But what's of interest is that rankle upregulates celic 15 receptors on osteoclasts, and that celic 15 it appears to be necessary to form multinucleated osteoclasts. So our objective in this study, similar to the objective of the study just discussed with you with sclerostin antagonism, is to see in a rodent model of complete spinal cord transection how effective this antibody is in preventing bone loss. And similar to the graphs just shown for sclerostin antagonism, there is a decrease in BMD after spinal cord injury, which is reversed with anti-celic 15 antibody. The same is true at the distal femur and the proximal tibia. And if one were to look at the effect of anti-celic 15 antibody to prevent bone loss in our electron micrographs, one can see that bone is pretty washed out in the spinal cord injured animals, but appears to be fairly preserved in the animals that have a spinal cord transection, yet at time of transection receive anti-celic 15 antibody. And once again, looking at the histomorphometry, that bone volume for total volume and trabecular number and connectivity are decreased after spinal cord injury and generally reversed with anti-Celic-15 antibody of note and different from the result that we saw with anti-sclerostin antibody, that if one gives anti-Celic-15 antibody, that there is some preservation, I'd say a good deal of preservation of connectivity. So let's move on to clinical studies that we're presently trying to recruit for. And this is where I need your help. I need to recruit patients to show either the efficacy or the lack of efficacy of sclerostin antagonism in patients with spinal cord injury. So the first study that I'm going to share with you is a study where we're looking at the efficacy of romosozumab versus denosumab to retain bone mineral density and architecture in an acute model. And the inclusion criteria are shown here. We're taking men and premenopausal women, ages 18 to 50, duration of injury less than or equal to 6 months, and these are upper motor lesions. The primary objective is to maintain at least 90% of baseline values of BMD at the distal femur, and the secondary objective is to maintain that magnitude of BMD at other regions of interest in the leg. We have exploratory objectives that will look at the microarchitecture of bone and the biomarkers. So this is a very straightforward study. Initially, we're going to give romosozumab and denosumab for 12 months versus denosumab only for 24 months. So the treatment group will receive denosumab for 12 months, followed by denosumab for 12 months versus denosumab for 20 months in the comparison group. And when we began this study, we were so fortunate because the pandemic hit. So it closed us down completely. And initially, we were going to do remote romosozumab versus placebo because our results from our denosumab study were so effective that our IRB insisted that we study the effect of romosozumab versus a drug that had tremendous efficacy to preserve bone during the first year of injury. So this is the study protocol. Different from the prior slide, you see that I'd like to give denosumab after romosozumab for 2 years versus 1 year. And, you know, it would serve everyone's purpose if we determined whether romosozumab, which inhibits resorption but does not inhibit bone formation, will be more efficacious than the denosumab therapy, which has a proven efficacy over the bisphosphonates, because in our hands, and I think very convincingly, it preserves bone after injury, both at the hip and the knee, versus bisphosphonates that appear to preserve bone only at the hip. The tests that we're going to perform, imaging by both DEXA and PQCT. We're going to do various blood tests and so on. Moving on to work in chronic spinal cord injury, the inclusion criteria are somewhat similar to the acute study, except we will also take individuals who are Asia grade C, who are mostly non-ambulatory, give or take 70% of the time. And the duration of injury for entrance will be 3 to 15 years. So we want to take individuals who have more or less plateaued somewhat of their bone loss at the epiphyses and may continue to be losing bone at the cortical region certainly will be continuing to lose bone. But we want them to have some bone loss, less than a gram per centimeter squared, but not totally washed out. So we want them to have at least 0.6 grams per centimeter square at the distal femur. So this study, we are able to compare romosozumab to placebo because there has been no evidence that any agent has been efficacious in those with chronic spinal cord injury. And then after 12 months of either romosozumab or placebo, denosumab will be given for an additional 12 months. Once again, we're going to do imaging studies, blood studies, some other ancillary studies as well. So I need your help. Please think of me whenever you see someone with spinal cord injury who may be interested in the work that we're doing, either in acute spinal cord injury, those who are injured less than 6 months, or those with chronic injury, those who are injured 3 to 13 years. You can refer them to either me or my research coordinator. What I'm going to try to do is to send a flyer to Tom Bryce so he can distribute it to members of the department so they're aware of the studies and the inclusion criteria and how to contact the research coordinators or me to assist in enrolling in subjects who are interested in participating. As a parting thought, pharmacologic therapy may certainly not hold the entire answer to preventing or reversing bone loss associated with spinal cord injury, and it may serve everyone's purpose to combine a potent pharmacologic therapy with a mechanical intervention. And many treatments in medicine have clinical relevance for a circumscribed period of time until something better comes along. I was very fortunate to be around when denosumab became available, and also was very excited when sclerostin antagonism, or romosozumab, became available, because it gives us the opportunity to test agents that may have tremendous efficacy in preserving bone, allowing individuals who have spinal cord injury to participate in upright activities without fear, or much lower fear of fracture. And I'd like to thank Dr. Ann Spungen, who has been extremely useful and has helped us in our experimental design. Chris Cernigliero, who has performed much of the hands-on work to get the studies done in those with acute spinal cord injury. The preclinical work was done under the guise of Chris Cardozo, and Wei-Ping Quinn did much of the animal work, along with Ye-Xing Peng and Lauren Harlow. We work very closely with individuals at Kessler Institute for Rehabilitation, specifically with Steve Kirschblum, who has been a collaborator and co-investigator with us for the past 20 years. At Rutgers, we are working with Scott Parrott, who is a fine statistician and was very generous with his time. The scanning electron microscopy was done by Dr. Fang at the University of Texas, and Amgen, Dr. Key and Ominsky provided us with reagents to do our sclerostin antagonism work in rodents, and Solomon Langerman permitted us anti-Selig 15 antibody for also our work done in rats. There was a review article that I wrote fairly recently that permits you to review in greater detail some of the work that I presented today, and I thank you all for your attention. All right.
All right.
So if anyone has any questions,
We do have a couple of questions on the chat right now.
Okay, let me see if I can get to the chat. Okay. So, what can it, I'm not sure. So I'll start at the top. So Julie has a question. Nope, that's not a question. So what was the question about tone and spasms? There is some work that shows that if one has spasms, one tends to hold on bone slightly better than if one doesn't have spasms. But, you know, spasms are not coordinated movement or physiologic movement. So, you know, you may get some benefit from spasms. And another way to look at it is if you have someone who is totally areflexic, they tend to lose a little more bone than if someone has some tone in their muscles. So what was the difference between the composition versus the architecture of bone? Well, bone is a mineral matrix. So the composition of bone is what goes into that mineral matrix compared to the structure of the bone, which is the architecture of the bone. Okay, my understanding is that taking calcium is a recipe for getting kidney stones. Okay. At time of acute spinal cord injury, individuals are at risk for kidney stones. And that is because of the tremendous bone resorption that occurs that, if you will, suppresses PTH. PTH is a hormone that permits calcium to be absorbed from the kidney. So without PTH, if you have elevated levels of ionized calcium, that calcium will just flush through the kidney. You can have very high levels of urinary calcium, and the individual is at risk for kidney stones. Of note, an article by Stewart, who is, I think it's Sinai now, if he's still there, showed that even if you limit calcium intake, and calcium intake was limited from about 1 gram to about 500 milligrams, there's really no difference in urinary calcium excretion because PTH is suppressed. So at time of acute spinal cord injury, when there's a high risk of kidney stones, even if you restrict calcium intake, you are not in any way limiting the amount of calcium that the kidneys excrete, and one is still at risk, whether one is on a high calcium or low calcium diet, one is at risk for kidney stones. However, after the acute period, there is a subset of individuals who are hyperabsorbers or hyper-excretors of calcium who would be at risk for kidney stones, even if they were not spinal cord injured. So give or take 1 in 20 or maybe 1 in 30 individuals will be at risk if they increase calcium intake. But for the vast majority of individuals, especially those who have the risk of skeletal deterioration, they may certainly benefit from a higher calcium intake, which would permit PTH to be in the more normal region, because if PTH is chronically elevated, that'll be a recipe for increased bone loss, whether you're able-bodied or spinal cord injured. Okay, were there any meds the same as Timlos? Help me. Timlos is what? That's the commercial name for what product? Is that abaloperitide? Who asked that question? Lenore, help me. Throw me a line. I can Google it. 1 second.
Thank you for the pictures.
Okay, it's Prolia, right? Oh, no, it's abaloperitide. Abaloperitide is a PTH analog. And the company that makes abaloperitide is Radius. And they were very interested in doing an acute study with me. Unfortunately, the pandemic hit and things fell through. Right now, I have my hands full doing an acute study with romosozumab, and there are no other PTH analogs that I'm aware of that are commercially available. There are PTH analogs that are being studied in preclinical studies, though. Okay, so there is a question here. Once bone loss occurs, there is no going back, question mark, question mark, question mark. Can anything rebuild, question mark? Well, question mark, I'm not sure. But it would make sense if one were a farmer and one had a cow. Would you want to keep the cow in the barn or leave the door open so the cow can leave the barn and wander around? The same is true with bone. If you lose bone, you lose both the mass of bone and, as I showed in an early slide, the structure of bone. So you have thinning and loss of connectivity between trabeculae, and probably loss of trabeculae completely. And as such, there is a real question as to whether the integrity of bone can be reversed once it's lost. So I think that one can possibly regain some of the mass of bone, but there is a real question whether it would be possible to once again restore the architecture of bone, which would then provide the best, or I should say, provide the maximum strength to resist forces. So obviously what one should do is, if one can, protect against bone loss. So anyone who is acutely injured at this time, in my opinion, should go on denosumab to prevent the loss of bone. All right, I am out of study. Okay. I'm not sure what John Kreutzberger is trying to say. I'm out of studies /61 in 15 years injury. Maybe 61 years old, 15 years of injury. Okay. So I don't think John would qualify for the study. Yes. Okay. I'm sorry, John. I think I handled most of the questions. If anyone in their clinical practice of medicine has questions concerning, bone loss, I am available. I am on staff at Sinai as a professor, so you can get in touch with me. And as I said, please, if you have anyone who could qualify for the acute or the chronic romosozumab study, the trade name for romosozumab is Evenity, please let us know, okay? And I will provide Tom with a flyer that can be distributed to members of the department. Tom Bryce. All right. Thank you all. Have a good evening. And I hope you learned something.
Thank you for joining us, everyone.
Okay.
All right.
Thank you, Ariane.
Yes.